So, welcome everyone to today's podcast, and we are diving into the area that's often recognized but critically important at the bedside: septic cardiomyopathy. We'll just see is it a distinct entity or just part of the sepsis spectrum, and to discuss all things, we have with us Professor Michelle Shu. She is a professor and senior consultant in the Department of Perioperative Medicine and Intensive Care, Karolinska University Hospital, Sweden. So, Professor Shu, first of all, before we jump to the discussion, would request you to have a focused presentation to lay out the current understanding of the septic cardiomyopathy. And over to you, Professor Shu.
Thank you so very much, Dr. Bharat. I'm so delighted to be here, and it's always lovely to see you and to be with our Indian colleagues, and I hope you're all well.
Yes, thanks.
So I will share my presentation with
please.
you.
Yeah.
Right, so the topic of my talk today is to ask ourselves whether echocardiography can define sepsis-induced myocardial dysfunction, and of course we will talk a little bit around how we detect it and how we treat it as well. So I do have some disclosures. I have received honorary and speakers' fees from these companies, and they're not related to this lecture. Now, let me ask you these 4 questions. Firstly, is sepsis-induced myocardial dysfunction best detected by echocardiography? And I would say yes, at the bedside, because there is no other tool that we can use at the bedside that will give us all the information that echocardiography will give us. I will come into that later. And then why cardiomyopathy? We quite often call this entity a septic cardiomyopathy. Well, I'm not completely confident that there is an actual cardiomyopathy per se, because I'm not confident that there is a primary disease of cardiac muscle. But if we accept that there is a cardiomyopathy, then there should be damage to the cardiomyocytes, right? And if there is damage to the cardiomyocytes, then troponin leakage should be obligatory. And then finally, this concept of reversibility that we see again and again described in lectures and presentations and even in scientific papers. So let's discuss this. So many of you will be aware of this really well-quoted paper by Margaret Parker from the 80s using synerangiography that described how septic cardiomyopathy is really defined by a low or poor contractility and increased left ventricular dimensions at the early phases of septic shock, but then this is completely reversible within 7 to 10 days. What is often forgotten is that this pattern is seen in survivors. But what Margaret Parker described was a whole spectrum of phenotypes, because here you see the non-survivors that do not have an impaired ejection fraction, nor did they have increased left ventricular dimensions. And these non-survivors do not follow the pattern of the survivors at all. So I question really whether or not sepsis-induced myocardial dysfunction is reversible, because it certainly seems to be reversible in survivors, but not so in non-survivors. And since then, there have been many papers produced about this, and this rather old meta-analysis from the Sydney group, the Nepean group, showed that there was no evidence to support that view with a decreased LVEF and increased left ventricular dimensions. And in fact, when we look at later meta-analyses, we see that the LVEF perhaps doesn't have a huge clinical relevance, although this meta-analysis may have some limitations. So in later years, we have learned to interpret left ventricular ejection fraction with a little bit more nuance. And although this was a large study and it was retrospective, it showed that perhaps by considering left ventricular ejection fraction as a linear variable, that we might not capture those important nuances. And here Sid Dugas showed, and his colleagues showed, that an LVEF that was very poor, less than 25%, or a hypercontractile heart, with an LVEF of more than 75% among patients receiving noradrenaline at high doses of more than 0.5 micrograms per kilo per minute. So this is a very selected population that LVEF was relevant, after all, for short-term mortality. Well, we all know that LVEF is easy to use. Most of us can measure it at the bedside, but it is incredibly load dependent. Well, tissue Doppler S prime, this is, another measure of left ventricular contractility, may help us, and it is supposed to be less load dependent, but tissue Doppler S prime doesn't seem to be very predictive or prognostic of mortality either. And this was another paper by the Filippo Sanfilippo group showing that regardless of how systolic function is defined using TDI, whether you use regional TDI or average tissue Dopplers, there was no relationship with mortality. Now, in later years, we all came to understand that global longitudinal strain was a more sensitive indicator of left ventricular systolic dysfunction. And indeed, it is in heart failure patients and in patients within the cardiology setting. Certainly, it is extremely prognostic of poor outcomes. And for you, for those of you who do use strain measurements, you will realize that it is not that easy to capture a really good 4-chamber view and a really good apical 2-chamber view in order to reconstruct this bullseye plot. But a bullseye plot is excellent. It's incredibly visual. It will give you an estimate of left ventricular contractility in all the sections of the heart. And here you see the blue is abnormal. The red is more normal. So the more negative, the higher the contractility. And here you see that the inferior septal and septal regions of this heart, suggesting that this could be acute coronary, an acute coronary syndrome, was affected, but this was in fact septic cardiomyopathy. Now, I have added the septal and lateral MAPC. So the MAPC is the left ventricular equivalent of the TAPC, the mitral null plane systolic excursion, that we took at the same time as this bullseye plot, and you will see that the septal and lateral MAPC reflect the GLS. Now, GLS is prognostically important in sepsis and septic shock, and this is another meta-analysis by Dr. Sanfilippo's group showing that GLS, if it is abnormal, so if contractility is poor, is strongly prognostic for short-term mortalities, although you see here that the effect sizes tend to vary quite widely. Nevertheless, this is a well-done meta-analysis with trial sequential analysis with the numbers of patients exceeding the trial sequential boundaries. So GLS seems to be prognostically important in sepsis and septic shock for mortality. However, there may be nuances in the data. Just like I showed you that nuanced data by Sid Duga with that U-shaped relationship between LVEF and short-term mortality, there may also be this kind of relationship with left ventricular strain. So this is, again, another study with left ventricular strain, but not predicting mortality as the outcome, but major adverse cardiovascular events. Now, I like this paper very much because you could question whether or not mortality is a relevant outcome when we're examining echocardiographic parameters. So major adverse cardiovascular events, and you see again this beautiful U-shaped relationship between global longitudinal strain, GLS, and MACE. However, this relationship only existed amongst patients with a history of cardiac disease. So again, this was a very selected sample where patients, where echocardiographic parameters may be prognostically important. So I mentioned previously MAPC, mitral null plane systolic excursion. Now, I like this measurement very much. There are some physiological features of it that I won't go into today that make it very, very attractive. I do not think that it is only an indicator of systolic function. I do think that it does reflect diastolic function as well. But nevertheless, we have shown, and others have shown, that MAPC predicts GLS very, very closely. They are highly correlated variables, and perhaps that is not so surprising because they do both measure longitudinal systolic excursion. However, we also know that MAPC is highly related with acute myocardial injury, and there is even one paper that shows that MAPC is a predictor of short-term mortality. And this is a recent paper that we published here showing how MAPC is strongly related to patients with myocardial injury. So MAPC is decreased amongst those patients with manifest myocardial injury measured as a troponin increase according to consensus definitions. Now, I mentioned about nuances in the data, and in recent years, we have come to understand that septic cardiomyopathy or sepsis-induced myocardial dysfunction may not just be manifested as a decrease in systolic function, and in fact, an increase in systolic function also occurs, so the hyperdynamic LVEF. And there are a few papers around that do show, as shown in this meta-analysis, that it may be related to an increased risk of mortality. So hyperdynamic increased LVEF associated with increased mortality amongst patients with sepsis and septic shock. Now, what about diastolic dysfunction? There has been a lot of talk for many years telling us that diastolic dysfunction occurs in sepsis and it may be related to mortality. And a huge number of papers published here, this meta-analysis favoring an increased mortality, but really not statistically significant. Because, in my opinion, because you see that the effect size, even though it was statistically significant, I think it is not a robust measurement, because you see that the effect sizes range very, very widely, and you see also that the effects go on either side of the line of unity. So that was another meta-analysis by the San Filippo group, and in a very recent publication, this was from Philippe John's group in France. They showed that left ventricular diastolic dysfunction was extremely prevalent amongst patients with septic shock. In fact, 76% of this population had diastolic dysfunction defined according to consensus guidelines. Now, I need to emphasize that in that meta-analysis and in most other papers, diastolic dysfunction was only defined according to one or two Doppler parameters usually, whereas in this paper, diastolic dysfunction was defined very strictly according to guidelines. So 76% day 1 to 3, but look here at ICU discharge, 56% still suffered from diastolic dysfunction, and at day 28, 44%. Diastolic dysfunction was not related to 28-day mortality, but these numbers here, 56% and 44% at day 28, raise some concerns. So is diastolic dysfunction a longer-term feature of sepsis-induced myocardial dysfunction, or is this a feature of pre-existing cardiovascular disease? And this is perhaps one of the greatest limitations of most of the echocardiographic studies that we have seen within critical care, that they do not take previous cardiovascular diseases into account. So abnormal right ventricular function also occurs commonly, up to 55%, but again, it depends on how it is defined. Now, there are consensus definitions. However, there are two other definitions: acute cor-pulmonale, which is defined echocardiographically as RV dilatation, so the RV to LV end diastolic area more than 0.6. plus septal dyskinesia. So that's the echocardiographic definition of acute cor pulmonale. So ACP is seen in 20 to 25% of a patient population with severe with sepsis and ARDS. And then there is also another definition, RV failure, coined by Antoine Baron and his co-workers. And he defined RV failure phenotype as a dilated right ventricle and a CVP of more than 8. It's really unclear which of these phenotypes are most important prognostically, but certainly in the COVID-19 population, ACP seems to be prognostically significant. Now, here is yet another meta-analysis. In this meta-analysis, right ventricular dysfunction was defined variably. It could have been defined as one or more of the variables that are guideline specified. It may be defined as ACP. It may just have been defined as right ventricular dilatation. But despite these varying definitions, you see that there is some sort of a relationship between right ventricular malfunction, I should call it, and short-term mortality, as well as long-term mortality. However, the authors did say that there was publication bias. You see that there are large confidence intervals of those estimates. So we really do not know what the prognostic significance of right ventricular dysfunction is for mortality in the short and long term. So we're back to this paper in 1997, and I want to pay tribute to Professor Jan Polliard, who left us last year. And already at that time, he defined sepsis-induced myocardial dysfunction as a large spectrum. It was a continuum from just isolated diastolic dysfunction to both systolic and diastolic severe ventricular failure. So there was this huge spectrum of disease. And in fact, this has been confirmed in a host of studies later. Now, I want to bring up this study. This is a secondary analysis of 2 or 3, perhaps, databases in France. And I think this is probably where we're heading towards in the future. So this is a machine learning model using hierarchical clustering to identify different clusters based on cardiovascular information. So not just echocardiographic information, but also hemodynamic information. And these authors identified 5 clusters. So cluster 1, the blue, is a well-resuscitated cluster. They had the lowest mortality. They had a normal LVEF. The delta SVC was not increased. There was no increase in the dimensions of the right ventricle, and so on. Cluster 2 was called left ventricular systolic dysfunction, and this was the cluster with the highest mortality, 50%. And you will see here LVEF markedly decreased. This was reflected in the left ventricular fractional area change. The diastolic arterial pressure was quite more or less normal, but the VTI was very low. And then you had other classes, hyperkinetic, you see here, LVEF in the orange, very high. And then you had the right heart failure cluster, which is interestingly, not surprisingly, had the highest RV to LVEDA, but also had low arterial pressures, high LVEF, and more or less normal or semi-normal aortic VTIs, and then finally the persistent hypovolemia. So LV systolic dysfunction was the cluster with the highest mortality, followed by the RV failure. However, what we know from that study is that there was a huge amount of overlap between the clusters. So it's very difficult to use these clusters clinically because none of these features will really define the clusters, perhaps LVEF in the systolic LV systolic failure cluster. But you see here, even in the right ventricular failure cluster, you see that there is a huge number of overlap between the clusters, and the RV to LVED, and in the purple group, which is the RV failure group, does not seem to stand out compared to the other clusters. So just to put it all together, I can just say that right ventricular and left ventricular dysfunction, they do occur commonly in sepsis and septic shock. We know from previous studies that they have been variably defined and quite usually investigated in isolation. Earlier studies showed that LVEF does not seem to be prognostically important, but perhaps we have been barking up the wrong tree by considering LVEF as a linear parameter. And in fact, there may be non-linear relationships where both ends of the spectrum do impact on clinically important outcomes. We are seeing that the longitudinal parameters, such as global longitudinal strain, as well as emerging data with MAPC, are likely to be important. But up till now, we are really uncertain about the relevance of left ventricular dysfunction. Similarly, with right ventricular dysfunction, this has been defined variably, usually again investigated in isolation. We know that the acute core pulmonale phenotype seems to have prognostic relevance, and this is particularly true for patients with COVID-19 disease. I'm so sorry, I've just lost my screen now. Yes. And then the right ventricular phenotype seems to be physiologically relevant. We know that if the right ventricle is dilated and you see that the interatrial septum is pushed towards the left, there will be some intraatrial as well as intraventricular interactions. This is physiologically relevant, but we really do not know if this is prognostically significant. So my take-home message to you today is that there are multiple echocardiographic manifestations of sepsis-induced myocardial dysfunction, and you cannot consider them in isolation. And sometimes, maybe, the simplest variables such as MAPC may be the most relevant. And we need to consider nonlinear relationships and no longer take these direct binomial relationships or directly linear relationships into account. And perhaps we would need to be looking at other outcomes other than mortality. And importantly, and this is what we do clinically, we need to interpret our echocardiographic variables within the context of the patient's previous and concurrent comorbidities and hemodynamic variables and even ventilatory parameters. So the prognostic relevance of individual echo parameters depends also on the chosen outcome. And I really think that we need to rethink the concept of sepsis-induced myocardial dysfunction. And until we take all of those considerations into account, we will forever be the blind man and the elephant, because everybody thinks that they are right, but in fact, nobody has the whole picture. Thank you very much.